Jai Hospital, presenting you diabetes and eye. What can I do to save my eye if I have a diabetes? Before starting, I would like to thank Guild member to giving me this opportunity to present here. Uh, what is diabetic retinopathy? Basically, it's a progressive dysfunctional of the retinal blood vessels caused by a chronic hyperglycemia. So it can happen in a type 1 diabetic patient as well as in type 2 patients. Initially, the DR, diabetic retinopathy, is asymptomatic. If not treated, it can progress and it will have a symptoms. So, what are the risk factors? Type 1 diabetes, around 70% will have a risk of developing DR. And in type 2 diabetes, it comes around 40%. If the type 2 diabetic patient is taking insulin, that risk goes up to 70%. So what are the risk factors? The main risk factor is the duration of the diabetes. The other is the poor control. And along with that, the other five factors are hypertension, nephropathy, or the patient is taking insulin, etc. Obesity also plays a role here. So if we see a prevalence of the diabetic retinopathy after 20 years of the diagnosis, the type 1 diabetic patients will have around 100% patients will have diabetic retinopathy, but that in type 2 patients will have 60% prevalence. So how does this thing happen? So when the patient is exposed to chronic hyperglycemia, it will have a microvascular occlusion, which will lead to ischemia, and that will lead to increased VEGF release in the vitreous cavity, which will form a new vessels in the retina, and that will lead to a traction or the vitreous hemorrhage, and that can lead to a tractional retinal detachment. So what are the symptoms? Initially, the patient will have no symptoms. Visual loss is a late symptom of the diabetic retinopathy. So, but if the patient develops the symptoms, it can be a gradual vision loss or the sudden vision loss. And other symptoms can be like floaters or the distortion of the images. Coming to the classification, we can classify it as a non-proliferative DR or the proliferative diabetic retinopathy. So NPDR is again can classify it as a mild, moderate, severe, and very severe. And the other entity is the macular edema. It can be called as a clinically significant macular edema. So I'm showing you here. This is the normal fundus image of the right eye and the left eye. Coming to the terms, diabetic macular edema, it is the only term, it is the only condition in the diabetic retinopathy which will have a symptoms at earlier stages. Otherwise, the patient will not have symptoms. And this is the only thing, the diabetic macular edema, which will contribute to the vision loss to the patient. So these are the hard exudates or the microaneurysms. You can see here, this is the macula and this is the optic nerve, and these are the vessels coming from that. So the macular area, if it has a hard exudates or the microaneurysm, the likely chances are there that the macular edema is there. If we do a FFA, it will have a leak over there. This is the FFA image, and even this is the left eye image. It also has a hard exudates and the microaneurysms. So this is a macular edema. So macular edema, the prevalence is more in the PDR patients compared to the moderate to severe NPDR, and it is very less in the mild NPDR cases. So other entity is the ischemia, so which will also have irreversible vision loss. Macular ischemia is the term where the patient will have a vision loss and we cannot recover it. Usually this will happen at very late stage if patient is ignoring the symptoms and if he has not got any treatment for that. Then these are some subtle signs of the ischemia. Like you can see here, this is the venous loop or the irma, which is present near the vessels. And if you see, now you can compare, this is the healthy retina and this is diabetic retinopathy eye. So there are some changes. You can appreciate that there is a hemorrhages, dot and blot hemorrhages or flame-shaped hemorrhages, hard exudates, soft exudates, which will develop if the patient is developing diabetic retinopathy. Coming to the classification again, the mild NPDR will have just some microaneurysms, some hard exudates here and there, less than one quadrant, 1 to 2 quadrants in the retina. But the moderate NPDR patients will have the same findings like the hemorrhages, hard exudates in more than 2 to 3 quadrants, but less than 4 quadrants. If the patient has the hard exudates and the hemorrhages in all 4 quadrants, then it comes to, then we classify it as a severe NPDR. It also has one more criteria of having venous looping and irma present. So if that is there, then it is a severe NPDR. But how is it different from PDR? So very severe NPDR is a one more term where the patient has more hemorrhages than the severe NPDR, but it will not have a new vessels. So as soon as the patient develops new vessels, we classify it as a proliferative diabetic retinopathy. So here you can see there is a ischemic area, and near to that the new vessels will develop and which will leak on FFA. So here also you can appreciate the new vessels are developing. Those new vessels can develop over the disc also, as well as over the other vessels or elsewhere in the retina. So when the new vessels develop over the disc, we call it NVD, neovascularization over the disc. If it is developing like in the other area, we call it NVE, neovascularization elsewhere. So this is NVD, the new vessels are over the disc, and this is the picture of NVE. You can appreciate the new vessels here, the frond looking like vessels. Here it is a picture of NVD and this is NVE. So here are some more pictures of the NVD. You can appreciate the difference from the normal looking retina. So what are the complications of the diabetic retinopathy? It can have a vitreous hemorrhage. These new vessels are very fragile. This will bleed and can form a vitreous hemorrhage, or it can form a subhyaloid hemorrhage. If the blood is collected at the subhyaloid place, it will have a subhyaloid hemorrhage. In that case, the patient will have more symptoms. Sudden vision loss will be there in subhyaloid hemorrhages as well as vitreous hemorrhage patient. And when the new vessels are developing, it can have a fibrous content in that. It can have a fibrovascular membrane. Here you can see this white looking thing is a fibrovascular membrane, and which can cause a traction over the retina, and eventually it will lead to tractional retinal detachment. So this is a picture of the tractional retinal detachment. Here you can see the retina is getting detached, and here also the optic disc area and the nearby area is getting detached. In this case, we have only option of the surgery, but the prognosis of such cases is really poor. These are some more pictures. If this is a very severe TRD picture, along with that it has developed a combined RD, you cannot appreciate the optic disc and the vessels. Here behind this is the optic disc. These are some more pictures. Here you can see the subhyaloid hemorrhages along with the TRD is there. Here also superiorly TRD is there. So how does the tractional retinal detachment occur? As I said, the new vessels will have a fibrous membrane, and it will cause a traction to the retina, and it will pull the retina into the vitreous cavity so that the retinal detachment will happen. So what are the management options we have? So the management we can divide it in the macular management and the other management. If the patient has diabetic macular edema, we do have an option of the intravitreal injection or the laser. The laser can be focal laser or the grid laser. We will do a laser here. It is a focal laser. We will target each and every microaneurysm in that area. But the disadvantage is that we cannot do that laser over the fovea. So other option is the grid laser. We can do the laser inside the macular area, but not at the fovea. And for that, the intravitreal injections comes into play. The other option is the pan-retinal photocoagulation. This is the picture of the PRP. Here we do laser over the extramacular area. And if the patient has PDR along with the vitreous hemorrhage or the tractional RD, we only have the option of the vitrectomy, that is a surgery. So what do we do in giving intravitreal injection? We give the injection at the pars plana level, and we put the injection inside the vitreous cavity. So it is an anti-VEGF injection. We do have a steroid injections as well. So what does those injections do? Basically, we have lot of injections available at present, but the main action is that it will reduce the load of the VEGF inside the vitreous cavity. That by it will reduce angiogenesis as well as reduce the vessel stability and the inflammation. These are some pictures. This is the OCT image of the macular edema before injection, and this is the after injection. So this is the improvement we can get if the patient gets the proper treatment at proper time. Coming to the last option we have, that is the surgery, pars plana vitrectomy. In that, what do we do? With the one vitrectomy cutter, these are the fibrous membranes. With that cutter, we have to cut the membranes and remove the tractions. And after removing all the membranes, we have to laser the retina after settling the retina. I would like to show you a surgery, one of my tractional retinal detachment surgery. So this patient had vitreous hemorrhage along with the tractional retinal detachment. So what I'm doing now here is I'm making 3 ports here and making an entry through the pars plana inside the vitreous cavity. Here I am making a anterior vitrectomy. झालं
का बरं?
नाही होते प्ले, नाही प्ले होत.
व्हिडिओ तरी प्ले कर.
So these are the 3 ports through which I am entering into the pars plana, from the pars plana inside the vitreous cavity. Here I am doing an anterior vitrectomy with the help of a vitrectomy cutter and the light source. Here you can appreciate a white looking thing. It is an old vitreous hemorrhage. The denatured blood turns out to be white in color. And as I am removing the vitreous hemorrhage, you can see here, this is retinal tissue I am able to see. But here also the bleeding is there. Now I am doing the core vitrectomy, removing all the vitreous hemorrhage from the vitreous cavity. After removing the vitreous hemorrhage, we could see the retina, like what is the retina, whether it's settled or not settled, and then we can decide about the further management. Here you can see this white looking thing, these are the fibrous membranes which is causing the traction and retinal detachment. So after that, I am removing those tractions so that the retina will settle. With the help of a cutter or the forceps, we can do it. So this is the one membrane I am removing, and thereby it may lead to more bleeding because these vessels are attached to the main branches of the vessel. So this comes the tricky part, because you have to take care that the retinal tissue should not come into the cutter, and there should not be a more bleed which will lead to the vitreous hemorrhage. So you can see the result. The membrane has been removed, the vitreous hemorrhage has been removed. Little bit bleed is there, but it will get absorbed after a month because you cannot remove all the bleeders. After removing all those membranes, we have to cauterize the pointers from where it is leaking or from where it is giving a new vessels. And after this, we have to do a fluid air exchange. Under the air, the retina will be settled, and after settling the retina, we have to laser the remaining area. So now you can see the retina is settled. All the membranes has been removed. The traction has been removed. Here is the final picture. This is the optic disc and the vessels. Some sclerosed vessels are there. And after that, I'm doing a laser of the remaining retinal tissue. These are the laser marks. These are the fresh laser marks which will look white in color. And after doing the maximum laser which we can do and settling the retina, we will put the silicone oil inside the vitreous cavity. We will keep the oil as much needed, minimum for the 3 to 4 months, and after that we have to remove the oil. It depends on the case to case. Sometimes we do have to put the gas also, and after that we can close the case, like suturing can be done, or sutureless. Nowadays we can do a sutureless vitrectomy as well. Coming to the presentation again. So the currently much disease is detected too late for the effective laser surgery. So what can we do to prevent this? The main thing is prevention. Primary prevention is strict glycemic control. The other thing is controlling BP, maintaining your low weight, maintaining the exercise and the good diet. The other thing is the annual eye examination, by which you can prevent these things to happen. And the last and the third tertiary prevention is the laser photocoagulation or the vitrectomy surgery. Just remember, every diabetic is a potential candidate for DR, and the initial symptoms are not there for the diabetic retinopathy. Average around 80 million people are suffering from the diabetes in our India. So all diabetics, I mean all 80 million people need fundus examination to screen the diabetic retinopathy. So what is the take-home message? So if the patient is having type 1 diabetes, we should screen. The first screening should be done at the time of 3 to 5 years after the diagnosis, and after that a yearly regular follow-up should be there. If the patient is suffering from type 2 diabetes, then at the time of the diagnosis itself we should screen the patient, and after that yearly follow-up can be done. And before the pregnancy, in type 1 as well as type 2 diabetic cases, prior to the conception and early in the first trimester, we should screen first, and depends on the stage of the disease, we have to follow again, like 1 monthly or 3 monthly, 6 monthly, like that. Thank you very much for the patient listening. I hope I have convinced you all to do checkup of your retina. Thank you.